Welcome to the third part of the INICET Video Power Pack Revision Series 2.0. This is the image related videos part 3, where we are going to cover the rest of the portion like cornea, we are going to cover conjunctiva, sclera, strabismus and neuro-ophthalmology. Understood? So starting with the conjunctiva, the first image, as you can see, what is this first image? So many times have been asked in the every exam almost, so you need to know about this. What is this? You can see the giant papilla here. So the diagnosis of this condition is, क्या है diagnosis इसका? Diagnosis is giant papillary conjunctivitis. Giant papillary conjunctivitis. And what happened? When this is happening? So the causes are, the first one is contact lens user. So contact lens is the one of the most important cause of these things. Second point क्या है? Second point is exposed sutures. If the sutures get exposed, like corneal sutures, conjunctival sutures or scleral sutures is exposed, it will continuously rub the conjunctiva and can cause this. Third, exposed scleral buccal. Exposed scleral buccal. You may be wondering what is buccal. Like you have a belt now, you wear a belt on the pant. Similarly, to treat retinal detachment, we put a belt or buckle around the globe from outside. If that buckle is exposed, then this can cause this one. So basically, giant papillary conjunctivitis is caused by the contact lens, exposed suture and exposed scleral buccal. Coming to this, I'm telling you that this is something nodular lesion with engorged blood vessels, phenyl administered, and this engorgement becomes like this. Means nodular lesions disappears, means it has resolved more or less. When this you are seeing, means on phenyl administration the lesion is going, nodular thing is going, then which condition is this? This is giving a diagnosis of nodular EP scleritis, and most common cause is idiopathic. Maybe because one of the questions they have asked, it can be maybe associated with rheumatoid arthritis. This is also an important MCQ. So maybe associated with the rheumatoid arthritis. So important to know about all these things. Now coming to the second question, second image, sorry. So let me tell you before you took any confusion. This image, the above image is separate, means this image is this and this both are connected. So above two images are connected, below two images are connected. Let me tell you what is the above image. It's very clear, it's very obvious. You can see there is a subtarsal conjunctival scarring. If there is a subtarsal conjunctival scarring, this is nothing but, what is this? Arts line, and this arts line is a feature of trachoma. Now this is also the feature of the trachoma, but what is this? This is the shallow depression here you see. Okay, this shallow depression is actually Herbert pits. This shallow depression is formed after the healing or cicatrization of the Herbert follicle. So this shallow depression is Herbert pits. Pit is depression, simple. Now you see here, there is a white raised nodular type of lesion at the limbus. What is this? This raised nodular type of lesion at the limbus is Horner Trantas spot, and this is seen in where? कहाँ मिलता है ये? VKC. VKC is vernal keratoconjunctivitis. If VKC is very severe, not treated in time, leading to the corneal involvement, then this type of ulcer can be there. What is this type of ulcer is there in VKC? This is SHIELD, sealed ulcer. Understood? So Art's line and Herbert pits are seen in trachoma, Horner Trantas spot, and in severe case sealed ulcer are a part of vernal keratoconjunctivitis, VKC. Got it? Coming to this portion. Identify what is this. I'm not telling you to identify because they will give the options, but see here what is happening here. See what is happening here. This eyelid, this is the eyelid, and this eyelid is adherent to the conjunctiva. So this, if the eyelid is adherent to the conjunctiva, conjunctiva means eyeball, okay, then it is called symblepharon. So this condition is symblepharon. But when upper eyelid is connected to the lower eyelid, at one or more places, this is called ankyloblepharon. Understood? So दोनों चीज समझने वाली बात है. Coming to the next image. What is this first image is telling you? Very simple. It's an elastotic degenerated thing. So it is nothing but it's very classical. Every time they will ask you this question. I will talk only about the specific things here. So this is basically nothing but a pterygium, right? Everybody agree? This is pterygium. So pterygium is encroaching onto the cornea. Which layer? कौन सा layer on the cornea? Which layer of cornea? Answer will be Bowman's layer. Remember one thing, it's an elastotic degeneration. Elastotic. Remember these words because they can ask you in the examination, because this is so much common that you need to know everything about the pterygium. So pterygium is nothing but it's an elastotic degeneration of the conjunctival tissues onto the cornea, encroaching into the Bowman's membrane. When will this happen? This happens because of UV exposure. So ये UV exposure के कारण होता है. And the treatment is obviously pterygium excision with conjunctival autograft. So treatment क्या है? Pterygium excision with conjunctival autograft. What is the most common cause of the diminution of the vision? If the patient is having the cornea then the diminution of vision is found there. Then what is the cause? The cause is astigmatism. So I will write here that most common cause of DOV is astigmatism. A very important MCQ. Got it? Now coming to this MCQ image. What is this? This is the frothy lesion on the temporal side of the conjunctiva. That is nothing but a Biot's spot. According to the xerophthalmia classification, WHO classification of night blindness, this Biot's spots come under grade 1B, and the treatment for this will be 1 lakh international unit IV or 2 lakh international unit IV. Sorry, I am not IV, oral. It is oral. डे कौन सा डे पे आता है? 0, 1 and 28. So if this is happening, so you have to give the vitamin A. Sorry, it's a vitamin A. Vitamin A on day 0, 1 and 28, 1 lakh international unit IV or 2 lakh international unit oral. This is a Biot's spot. It's a manifestation of vitamin A deficiency or xerophthalmia. Understood? I mistakenly told night blindness. It's not night blindness. It's a xerophthalmia wala thing I'm telling. Now, can you see and identify this image? The first image. This is the conjunctiva. Lower lid has been everted and some membranous lesion is there. This is nothing but membranous conjunctivitis. Cause, organism, corine, bacterium. One thing remember, wherever there is a membrane formation, in most of the case, corine bacterium diphtheria is the cause. चाहे वो throat में membrane बनाना हो या कहीं आई के membranous conjunctivitis की बात हो, wherever the membrane is formed, generally corine bacterium diphtheria is the cause. Understood? Now, look at this image. You can see this is the image lesion and the hair follicles also. So basically, this is a dermoid lesion. Dermoid lesion. It's a congenital something type of lesions, and the treatment is patch grafting. Corneal patch grafting. Yes, it's a type of keratoplasty, but only this portion has to be excised and has to be replaced. Can you see the image? Yes, you can, I think. Okay, so what is this? You can see the blue sclera type of things. It's nothing but because of the thinning of the sclera, that underlying structures is trying to protrude out. And why the sclera is thin? Because of some connective tissue disorder. So basically, this is a classical picture of what? This is a classical picture of scleromalacia perforans, and most common association क्या है इसका? Most common association is rheumatoid arthritis. So it can rupture from here, it can cause the anterior staphyloma here. So it's very important to understand this. Coming to this photo, can you see this? What can you see here? चलो बताते हैं ये क्या है. What is this? This is hypopion. Okay, hypopion. Oh. This is nothing but this is hypopion. What is this? This is a fluffy lesion. Fluffy lesion with feathery margin. And if I tell you this patient is having a history of animal tail injury into the eye, or he's a farmer, then you have to think of only one thing. What is that? Fungal ulcer. Fungal ulcer में important pointer, this hypopion is fixed and unsterile. Okay, in fungal ulcer. Fungal ulcer में important point to note is this is the satellite lesions will be there. Satellite lesion is also a feature or very important feature of this one. Treatment 5% natamycin. Understood? Now coming to these two images, very important, as we already learned about bacteria, fungal corneal ulcer. We have to think one more important thing. Let me write to you. Let me tell you. I will tell you later. This, what is this? You can see there's a ring type of lesion or ring type of lesion with an abscess here. So basically, ring ulceration or ring abscess. Ring abscess is a feature of what? If I tell you it's a ring abscess or ring ulcer, it's a feature of acanthamoeba. So it's the acanthamoeba feature. Now in acanthamoeba, what is happening? Generally contact lens user में देखा जाता है. So there will be a typical history of a contact lens user going to the swimming pool, right? Or he is not cleaning his contact lens. So the most specific or अगर पूछा जाए organism is related to the contact lens. Most specific organism related to the contact lens is acanthamoeba. And you have a feature here like this. Are understood? Culture what will you will do? Culture यहाँ पे अगर करना होगा तो आप करोगे non-nutrient agar enriched with Escherichia coli. So ये acanthamoeba का ये कल्चर है. ट्रीटमेंट आई ड्रॉप PHMB, polyhexamethyl butyrate. So PHMB is the treatment of acanthamoeba. One important thing to understand in this acanthamoeba, symptoms is more than sign. Means the patient will have very severe pain, very severe pain, and when you see the cornea, it's nothing like that. Understand? So symptoms is more and more than the size. Because of why there is a severe pain, but there is no sign or very mild sign. It is because of radial keratoneuritis. Means there is a corneal nerve involvement is there. That's why. Okay. So this is about the acanthamoeba. Now coming to this, can you see what is this? क्या है ये? What is this? And what is this? These are the dendrites. Dendrites. And where you see these dendrites? You see the dendrites in the viral केराटाइटिस, दिस वायरल केराटाइटिस में आप यूज कर सकते हो इसको, ठीक है। हाउ यू हैव स्टेन दिस, इसको स्टेन करने के लिए आई हैव यूज्ड फ्लोरेसीन स्टेन एंड कोबाल्ट ब्लू फिल्टर से हमने, आई हैव सीन इट विद द कोबाल्ट ब्लू फिल्टर, फिल्टर सही नहीं आया है, so I have seen this. Now in the viral keratitis, what happened, obviously corneal anesthesia or hypoesthesia. So इसमें क्या होगा, corneal hypoesthesia means corneal sensation decreases. One, in viral keratitis you see the dendrites here, so avoid steroid because it can lead to geographical ulcer. Understood? What is the cause of this? HSV, herpes simplex virus is the causative organism of this, and treatment is 3% acyclovir ointment 5 times per day for 24 days. So this is very important to understand this fact, okay? Now coming to this important signs of something called very important keratoconus, right? तो मैं बता देता हूं कि these are all the signs of keratoconus के साइन है, right? So ये keratoconus के signs है. So the first sign, what is this first sign? When the patient is seeing downward, there is a V-shaping of the eyelid. This is called Munson sign. Munson sign. Right? What is this? On retroillumination of the slit lamp, you see some oil droplet type of reflex. This oil droplet type of reflex, also known as, इसको मैं लिख देता हूं oil droplet sign or Sherlock's sign. Oil droplet sign है या फिर Sherlock sign भी हो सकता है. Now what is this? They, you can see here, यहाँ देखो भाई, there is something bright on the edge of the cornea when the light is coming from this direction. So oblique illumination में when the light is shining on the edge, this is called Rizzuti sign. इसको क्या बोलते हैं हम लोग? Rizzuti sign. So this is also a sign of keratoconus. Now what you are seeing, there is striations of the cornea on slit lamp. This striation is nothing but it is called walked stria. ये walked stria है. Let me tell you what is this walked stria. It is pathognomic. It is pathognomic of keratoconus. Understood? So these are the signs of the keratoconus. Munson sign, V-shaped of eyelid on looking down, Rizzuti sign, oblique illumination, there is a signing at the corner, retroillumination, there is an oil droplet sign, and vertical, remember, vertical striations of the cornea, walked stria, and it is pathognomic of keratoconus. Remember, when you have a keratoconus, you need to treat this. There are so many methods of treating the keratoconus. The first one is correct spectacle correction, correct glass. Second one is you can go for something called this. A very important famous question in examination. So nothing to worry. What is this? This is called intracorneal segment, also known as INTACS, intacs, intracorneal segment, right? So when you put this segment, can you see this segment? When you put this segment inside the cornea, it flattened out the central formation. Similarly, keratoconus is a conical appearance of the or conical shape of the cornea, right? When you insert this into the cornea, it will stretch. The central portion will get flattened out and thus correcting the keratoconus. So it is used in the treatment of keratoconus. ट्रीटमेंट करेंगे इसको. This tool investigation is only for the namesake. You need to know only the name. What is this? This is actually a pachymetry. You have a different curvature. You have a curvature, anti-axial curvature, elevation map, depression map, deviation map, and corneal thickness map. So these are the different types of maps that gives the correct pachymetry. So this is actually pachymetry. Actually a pentacam hai, but you remember it like a pachymetry because it is easy for you. ये pachymetry है. Understood? What is this optical investigation? Basically, these are the Myers which is seen in one optical investigation for the cornea. So, which investigation? Remember, it is seen in keratometry. So, this is very important. In keratometer, this Myers are seen and perfect alignment will give you the value. No need to go into details. This is again an optical instrument for corneal curvature only. The name of this instrument is Placido disc, and it is used for corneal topography. Topography is related to curvature only. Curvature, thickness, elevation, everything gives a topography. So basically the answer of use of this is for the corneal topography. Understand? Looking at this picture, what you are having a likely to develop which type of keratitis here. So basically the skin is inflamed, as you can see here. The whole of the skin is inflamed. ये पूरा skin inflamed है. Means there is a vesicles type of thing. यहाँ vesicle, यहाँ vesicle, यहाँ vesicle. Everywhere there is a vesicle. Basically it is the skin involvement along the dermatome of trigeminal nerve. If there is a trigeminal nerve का involvement, vesicular lesion होता है. It's a viral. And what among that viral? Herpes zoster. So herpes zoster है यहाँ पे. Herpes zoster ophthalmicus. In this condition, you will find a Hutchinson sign. Hutchinson sign. There is a lesion on the side of the nose and along the dermatome of the trigeminal nerve. यहाँ पे भी होगा, नाक में भी होगा, साइड में, टिप side and along the dermatome of the fifth nerve. So ये dermatome है and here side में भी होगा और tip पे भी होगा. That is Hutchinson sign found in the herpes zoster ophthalmicus. Now the question is saying which type of keratitis. Basically this becomes so evident, so type. Then the type of keratitis is, answer will be nummular keratitis. Which type of keratitis? Nummular keratitis will be there. Understood? पहली बात, you cannot learn everything in single frame. If you learn everything which is specifically on, then you will remember for more. If you learn everything in a single phase or at one place only, difficult. I will provide you proper material, but for the image, I am breaking down everything. Don't worry, you will get. Okay. Now, what is this? Okay, what is this? Let me clarify. These both of the things are nothing but corneal dystrophy. ये दोनों चीज हम बात कर रहे हैं corneal dystrophy की, right? So corneal dystrophy basically इसका फीचर होता है, corneal dystrophy are the non-inflammatory, ठीक है, bilateral, प्रोग्रेसिव होता है एंड नो सिस्टमिक इन्वॉल्वमेंट. सो ये भी एक फीचर है, नो सिस्टमिक इन्वॉल्वमेंट एंड बायलैटरल होना एक फीचर है. सो दिस टू आर द थिंग्स इंपॉर्टेंट. अब समझने वाली बात है कि कैन यू सी हियर देयर इज अ lesion here, but it is very discrete lesion. You can easily see this gap. There is in between the two lesions, there is a very distinct gap. So it is the gap here. So gap here. Okay, but here lesion. So in between lesions, there is a no gap. So it is the gap between lesion present. So if a gap between the lesion is present, G for gap and G for gap, just remember G for granular. G for granular corneal dystrophy. So gap is G for gap. If there is a gap between the lesions, then it's the granular dystrophy. How to remember? G for gap, G for granular. And other one, no gap, nothing like that. This no discrete lesion. Go for macular dystrophy. Understood? Now, few important things regarding the corneal dystrophy. So मैं बात करता हूं most common corneal dystrophy. बताओ most common corneal dystrophy. map dot fingerprint और कोगानरीज दोनों सेम है. सेकेंड, Bowman's layer dystrophy. Name. Basically, remember, in the new classification of the corneal dystrophy, there is no such term like Bowman's layer dystrophy, but they can ask the exam because this is a very favorite exam question in the past, so they can ask. That is why I am mentioning here. But in the new classification, there is no such Bowman's layer dystrophy as a separate classification. Remember? So for the sake of exam, I am writing here Bowman's classification can be Rees buckler and Thiel Benke. So in the Thiel Benke, we have a honeycomb appearance. Understood? ये दो क्वेश्चन हो गया. Now I am drawing a very important table for this stromal dystrophy. Stromal dystrophy में कुछ चीजें जाननी है. There are three most common stromal dystrophy like lattice, granular, और मैकुलर. कुछ चीजें समझो, उस चीज को समझने के बाद बात करते हैं. इनहेरिटेंस, autosomal recessive, autosomal recessive, autosomal dominant. Got it? उसके बाद डिपॉजिट. डिपॉजिट क्या होता है? एमाइलॉइड डिपॉजिट, हाइलाइन डिपॉजिट and mucopolysaccharide. Mucopolysaccharide. Stain. Stain is the Congo red stain. Okay, and is Mason trichome stain. And one more thing, mucopolysaccharide is Alcian blue stain. म्यूको में मैकुलर में M है, मैकुलर में M हो गया, mucopolysaccharide हो गया. So basically this is the important thing to understand and you need to remember. To this next image, दो community के images हैं. It's very important to understand. This logo is of which program conducted by national program, right? So this image is actually the image of national program for control of blindness and visual impairment. इसको we can write it as NPCB VI. So this is this. There's so many things we will discuss under this NPCB program in our separate section. What is this pyramid is for? Nothing to be afraid of. It's the pyramid of vision 2020. Yes, it's a pyramid of vision 2020. Got it? Now we are going to discuss about a strabismus and neuro-ophthalmology portion right here, right now. So this image is very important to understand. You see, the first image is actually, this is the grading of binocular single vision. So for the binocular single vision, we need all these three things. So this is nothing but this is a grading of binocular single vision. So this is the grading of binocular single vision. Now what is happening here? Here there is a parrot, there is a cage. Now person, if there are two images, but person perceives that the parrot is inside the cage. When these two similar or dissimilar objects seen separately, but they are getting like this is nothing but it is simultaneous perception of the two different image. So this is a grade 1. What is this? This is grade 1, जिसको मैं बोलता हूं simultaneous perception. This is simultaneous perception. Now you see this rabbit and this rabbit. The difference is this rabbit is holding one flower. What a patient can perceive, a patient will perceive this image. Okay, that means two similar objects only differ by a minor changes can be seen as a complete image. That is called fusion. It is grade 2. It is a fusion. So ये fusion है. Now you see this inner circle is tilted here, shifted left. This inner circle is shifted right. But our eyes perceive this, normal eyes. Perfect centration of the circle. That is the depth perception. That is grade 2, grade 3, sorry. That is grade 3 called, wait a minute. That is stereopsis. So stereopsis में depth perception होता है. There is a depth perception. So basically, if you know about all these things, means for the binocular single vision, you have to be these 3 grades should be there: simultaneous perception, fusion, and stereopsis. So they can ask all these 3 in separate MCQ. They will give you this. What is this? This is simultaneous perception. They can give you this image. They will say, what is this? This is the fusion. They can give you this. They will ask, what is this? This will be a stereopsis. And all of them are a part of binocular single vision. I hope you remember all this. SFS. Okay. Now, coming to this image. This image is very much important. Have been asked in INICET, have been asked in FMG, NEET, everywhere. Basically, what I am indicating, it is nothing but it's a Hertzberg test. क्या है ये? Hertzberg test है. So when you put a light on the cornea, and if the light reflex is seen in the center, it is 0 degree. When the light falls on the pupillary margin, it is 15 degree. ये है ना 15 degree. If the light falls here, it will be 30 degree in the middle of the iris. And when the light falls at the iris limbus, it is 45 degree. Understood? So basically, different light is there. Okay, and you know, these are all degree. 1 degree, and you know, one degree is equal to 2 prism diopter. PD मतलब prism diopter. So if the examiner asks about PD, then you have to double the value. It is 15 degree matlab 30 PD. If it is 30 degree means 60 PD, and if it is 45 means 90 PD. So they can ask this, the examiner can ask this in degree or in PD also, prism diopter. So you have to remember 1 degree is equal to 2 PD. All understand? Second important confusion we can come. They can ask you 15 degree, they can write like 15 degree exo or 15 degree iso, exotropia or esotropia, whatever. Basically, if I is outward, then you write exo. If I is inward, then you write iso. No confusion in that. Rest will be same. Understood? What is this test and what is this test? You see here, this is the normal patient. You see, this is the normal. यहाँ पे normal है. Now you cover it. ये cover कर दिया. I move inward. You will not notice. I just for the demonstration purpose. I is moving inward. When you remove it, you will see I is moving towards this direction. That means and becoming normal. Similarly, here when you put this, I is moving, I is exophoric, and when you remove this, you will find that it is going in this direction. So what is this test? You cover it and then you uncover it and then you realize something movement is there. So normally it is normal. You cannot see any type of deviation here. But on covering and uncovering, you will find some rotation, some movement. Okay, that means it is not manifested squint. It is latent squint, and latent squint is phoria. Manifested squint is tropia. Latent squint को हम लोग बोलते हैं फोरिया. It can be exophoria or it can be esophoria. और manifested squint we call tropia. It can be exotropia or esotropia. Understood? See here on covering nothing, normally no any squint. Cover and on uncovering you will see some movement. There is a movement after uncovering, means some squint may be there. That means this test will give you an idea of some latent squint. So what is this test? This test is cover uncover test, and it will give you an idea of phoria, exophoria or esophoria. Understood what is this test? Now coming to this, what is this prism? ये prism bar इस तरह से लगाया हुआ है ना, this is called prism bar. और prism bar टेस्ट के लिए करेंगे एंड फॉर स्क्विंट इवेल्युएशन के लिए यूज करते हैं. वी यूज इट फॉर द स्क्विंट इवेल्युएशन. That's it. I have just given you as an example that they can ask in exam. That's why. Now this is very important. There is a red green glass. You can see red glass, no glass. Actually, it's not a glass, it's a rod. You see there is some cylindrical rod here in this. This is called, what is this? This is called Maddox rod. So basically, this Maddox rod converts the point light into the line. This Maddox rod converts the point light into the line. So with right eye, this patient will see a line, and with left eye, the patient will see a dot. Understood? Now, if the red line and the dot coincide, that means patient is normal, eye is well aligned, and this condition, this normal condition is called orthophoria. Okay? And if there is no alignment, no perfect alignment, that means there is no orthophoria. Now see, since the right eye is having the Maddox rod, and this line is also on the right side, right side Maddox rod, right side line, that means, and this dot is on the left side, that means it is not crossed, so it is esophoria, right? Similarly, if the right line, if the red line is on the left side, patient is having a Maddox rod on the right eye, but this red line is on the left side and the dot is on the right side. So there is a crossing, right, left. So there is a crossing. If the image is crossed, it is exophoria. समझ गया? Right eye Maddox rod, left side image. Right side Maddox rod, left side image. That means there is a crossing. X, remember, X is crossing. So if there is a crossing, then there is a exophoria, and vice versa is esophoria. Now you will remember. I'm telling you this test. A patient wear the red green glass, and he is seeing this image. This is image, and this image. This test is worth 4-dot test. So a patient is wearing red and green glass, and he is trying to see this 4 dots. When the patient will perceive this image, it is normal. Patient does not have any diplopia, patient does not have any esophoria, कुछ भी नहीं है उसको, ठीक है? But when patient is seeing only two red dot, that means patient is not able to see green dot, right? There is no green dot here, means green lens is on the left side, means left eye is not forming any image. That means left eye is suppressed. So this, when there is a no green light, means left suppression. Okay. Similarly, here there is no red light. No red light. That means right eye is not forming image. That means right eye is suppressed. So here right suppression. Now you see both green and red light is seen, and number of dots is 5. Here only 4. Actually, this is only 4, but he can see more than that. And all the red light and all the green light. That means both eye are not corresponding to each other. That means there is some sort of discoordinates and they produce diplopia. So patient is having diplopia. So basically one's fourth test is trying to see the suppression of the eye or the diplopia. Okay. Now you see the interpretation now. This is a test in the squint evaluation for that is called Titmus flight test. You just remember the name because they have asked only the name. No need to go into the detail. Titmus flight test. Now, only the name. What is the name? Just put your brain here. Hess charting. This is a Hess charting for extraocular muscles, palsy, suppression, like that thing. So this is nothing but this Hess charting. Understood? Hess charting. Oh ho. You love this, na? Everybody love this. Why don't fall into the trap of anything? This is a very simple thing. With this 9-gaze image, 3, 9-gaze image, they can only ask 2 or 3 questions like third nerve palsy, superior oblique palsy और lateral rectus palsy. बस और कुछ नहीं पूछ सकते हैं वो. And A pattern or V pattern, that's it. I am telling you only the few examples here. You see, सबसे पहले for this type of question, the first thing what you will see, the first image in this 9 image, the first image you will see center one. So I will see the center one image. Oh, what is happening here? You see there is a ptosis. यहाँ तो ptosis है इसको. Okay. Now you understand the patient is having ptosis, right? Ptosis. Now you see this 4 image. You see this thing. You see this image, this image, this image, and this image. After that, so what is happening in upper side? This cornea is moving up, but this is not moving up. In the lower side, both of them are moving up. Here in this left side, what is happening? Oh, good. This is also moving. This is also moving. But in the right side, this is moving, but this is not moving. So यहाँ पे गड़बड़ है. There is a medial rectus palsy here. इस लेफ्ट आई का medial rectus palsy. तो यहाँ पे MR palsy है. MR palsy, right? यहाँ पे भी प्रॉब्लम है. This is going up. This is not going up. यानी कि यहाँ पे some palsy, elevator palsy है. Elevator palsy. Similarly, now we will see this. अब हम लोग ये देखेंगे. What is happening? This can go up. This is not moving. Similarly, this can come here. This is not moving. Means adduction is difficult. Overall, if you see, that is medial rectus का भी palsy हो गया है. Elevator palsy हो गया है. All these palsies are there. Ptosis. तो कौन से नर्व का पाल्सी होगा इसमें? थर्ड नर्व में फिट होता है, लेटरल रेक्टस से फिट होता है? नहीं होता है. Only you have 2 or 3 options. You think only in the 2 or 3 options. Options can be, अगर options बहुत सारा हो सकता है, थर्ड, फोर्थ, सिक्स्थ cranial nerve palsy और A pattern and V pattern. So I'm not talking about this. I'm talking about among 3, 4 and 6. किसमें होगा? 6 तो होगा नहीं because lateral rectus is perfectly working. So 6 गया. Superior oblique is in. Superior oblique क्या कराता है? Superior oblique inferior movement कराता है. तो superior oblique में inferior is good ना? Superior is affected. So superior oblique, superior rectus और inferior oblique. So यहाँ तो या तो superior oblique, sorry, inferior oblique, या तो inferior oblique होगा या तो superior oblique rectus होगा. Both of them can be affected. So MR palsy, IO palsy, SR palsy, ptosis, all this indicates towards third nerve palsy. First and foremost thing, when you see the ptosis, go for third nerve palsy. When you see the ptosis, go for third nerve palsy undoubtedly. That's it. Okay. When you see some lateral rectus palsy, go for sixth nerve palsy. And when you see the patient is having difficulty in seeing down, that means inferior, patient is not able to see down, go for fourth palsy. That's it. ये very simple सा trick है, ज़्यादा दिमाग नहीं लगाना. Now nuclei of the marked nucleus nerve supply. अरे भाई, एक schematic diagram है. This is a schematic diagram. The idea is to make you understand why I am giving you. They can give like this now. This is a very typical INICET type of question. But so कौन से मसल्स की बात की जा रही है? They are talking about this muscles coming from here and then here, right? They're talking about this muscle. Only one muscles which got hooked somewhere in the bone. Only one extraocular muscles which got hooked somewhere in the bone, that is called trochlea, and this muscle is, that's why this muscle is superior oblique. That means we have to find that the superior oblique muscles के बारे में बात कर रहे हैं. तो superior oblique is supplied by fourth cranial nerve. That means हम बात करेंगे fourth cranial nerve के न्यूक्लियाई के बारे में. तो चलते हैं, हम सबके बारे में बात कर लेते हैं, केवल फोर्थ के बारे में. Why we will talk about only four? We will talk about all. हम सब तीनों के बारे में बात कर लेते हैं. फर्स्ट, थर्ड cranial nerve, third cranial nerve, fourth cranial nerve and sixth cranial nerve. You know what? Third cranial nerve is in the midbrain. Nuclei is in the midbrain. Superior colliculus. Fourth cranial nerve, that is this one. Midbrain only. This nuclei in the midbrain only, but inferior colliculus. And the sixth cranial nerve is in the pons, and it is rounding the facial colliculus. So the answer for this MCQ is this one, inferior colliculus. Understood? समझ में आया? You have to identify the nerve, muscle, then going to the nerve, and then the colliculus. Third and fourth, midbrain, superior and inferior colliculus. Third and fourth, midbrain, superior and inferior colliculus. And the sixth one is pons, facial colliculus. That's it. Now coming to the next image. Oh, again. What I told you. First, see the central image. Can you see the central image? यहाँ देखो, ये देखो. It does not look like any abnormality here. Now you see here, here, here and here. ऊपर में देखो. नो सिग्निफिकेंट चेंजेस। हियर यू सी, इस तरफ देखो, बोथ ऑफ देम आर गोइंग गुड, नो सिग्निफिकेंट चेंजेस। नीचे देखो, बोथ ऑफ देम आर ठीक है। इधर देखो, ओहो दिस इज गोइंग हियर बट ये तो नहीं मूव किया। यहीं पे लेटरल रेक्टस पाल्सी हो गया इसका। यहीं यहीं अरे यार, यहीं पे लेटरल रेक्टस पाल्सी हो गया। Wherever they are seeing lateral movement is problematic, that means यही आंसर हो जाएगा 6 नर्व पाल्सी। I mean to say, when you see in this type of question, when you see the ptosis, third nerve palsy, in this type of MCQ, when you see the lateral rectus, there is no lateral movement is there in any of the gauge. Lateral rectus palsy. And in this type of image, when you see the patient is having difficulty in inferior, not able to move his eye inferiorly, superior oblique palsy. यही ट्रिक है, इतना ही पूछेंगे. This much they will ask only, nothing more than that, because they know that you cannot go into deep now. Don't go trouble yourself. Don't trouble yourself. Be happy. Oh, most recent question in exam. मजा आएगा, समझते हैं, समझते हैं इसको. Baseline में both of them are looking normal, but the way the patient is trying to see in this direction, oh, normal, no problem. But when they try to see the left, जब ये इधर देख रहे हैं लेफ्ट, यहां पे प्रॉब्लम क्या हुआ? This side, no adduction, no adduction in this eye, and this eye is having nystagmus. When such thing is cropping up, that means there is some lesion somewhere. Where is that lesion? That lesion is in right, because there is adduction is not happening in the right side. That means right medial longitudinal fasciculus MLF lesion is there, and it is leading to right, wait a minute, and it is leading to the diagnosis of right internuclear ophthalmoplasia or INO. Remember this INO. So this is a case of internuclear ophthalmoplasia, right internuclear ophthalmoplasia, because right eye is not showing adduction. So it's a right internuclear ophthalmoplasia because of the lesion in the right MLF, medial longitudinal fasciculus. दोनों exam questions हैं. They can give you this image and they can ask you where is the lesion, MLF lesion. Okay, now how to remember this? Let me tell you the trick. Internuclear ophthalmoplasia, you can write the internuclear ophthalmoplasia like INO, right? If you can write here, IN के बारे में लिखेंगे, I can, sorry, INO, I can write ipsilateral nasal movement defect. Ipsilateral nasal movement defect means obviously adduction defect. So ipsilateral nasal movement defect. Okay, and what about this NO, nystagmus on opposite side? Nystagmus, this is opposite side, left eye is opposite side, that means there is a nystagmus. So nystagmus on opposite side. So if you know the I and O, internuclear ophthalmoplegia, then you can identify, you can make out the feature of this I and O. You can make out the feature ipsilateral nystagmus, ipsilateral nasal movement defect, and this NO is nystagmus on opposite side. So if it comes not in the image form, if the question is coming in the written form also, you can deduce with the help of this. Okay, okay now. So this is about the internuclear ophthalmoplegia. Now coming to this very important thing, I will go into in a very lenient manner. I will be very specific. I'm not going to discuss about the visual pathway, nothing. It will confuse you. Just remember one thing. Just remember, what is this? Temporal half, temporal half. That means it's a bitemporal hemianopia, and the lesion will be in the optic chiasma. Example, pituitary adenoma, can be the cause of this. Understood? What is this? This is homonymous, because this is on the same side, na? Nasal side, homonymous hemianopia. So homonymous hemianopia will be caused by all the lesions of the visual pathway behind the optic chiasma. And what is behind the optic chiasma? After optic chiasma, there is in the visual pathway, after optic chiasma, there is optic tract, optic radiations, lateral geniculate body, occipital cortex. So anywhere behind the optic chiasma, if there is a lesion, then homonymous hemianopia will be there. Okay, so it is the right-sided homonymous hemianopia. That means left-sided lesion. Left-sided lesion. Right-sided homonymous, ये right side है. So it will be a left-sided sided lesion. Where the lesion will be where? Behind the optic chiasma. Behind the optic chiasma means optic tract भी हो सकता है, ऑप्टिक रेडिएशंस भी हो सकता है, LGB भी हो सकता है, लेटरल जेनिकुलेट बॉडी, और ऑसिपिटल कॉर्टेक्स. Anything can be possible. But remember, if they will give you this question, that there is a homonymous hemianopia, but nothing, this is spared. This is called homonymous hemianopia with macular sparing. If there is a homonymous hemianopia with macular sparing, then the lesion is straightforward. Since this is the left-sided, ना, ये left-sided homonymous है, so there will be the right occipital lobe lesion. ये occipital lobe lesion हो जाएगा. Very straightforward answer. Now, इट्स द क्वाड्रेंटोपिया। दिस पाई वाला चीज को ना समझो, ये इसको हम लोग वी कैन आल्सो कॉल इट, हम लोग इसको क्या बोलते हैं, quadrantopia. Why quadrantopia? Because only one quadrant is involved here. This is called pie in sky, this is called pie on the floor. Pie in the sky very simply means pie in the sky and pie in the floor. Okay, so remember our trick. The trick is very simple. We have the parietal lobe up, occipital lobe down. Okay, parietal lobe up, occipital lobe down. So ऊपर का नीचे, up to below, below to up. It is like when there is a superior visual field loss, that means some lower thing is lesion. ऐसे नहीं समझो. So pie in the sky is because of parietal lobe lesion, sorry, occipital lobe lesion, and pie on the floor is because of parietal lobe lesion. Understand the fact that, remember one trick, no need to put your brain into it. Oh, in the floor there is a O for occipital. Remember that O for occipital is not the cows. Occipital है यहाँ पे, occipital is not the O है यहाँ पे, occipital is not the cows, parietal is the cows. Opposite, or O pie on the floor, O is not the cows, other one is the cow, that is parietal is the cows. वो दूसरे का cows होगा. ऐसे याद रखना पड़ेगा, because if I go into the details of making you understand this, ये बहुत hodgepodge हो जाएगा. What is this? This is a morning glory flower. This is a morning glory flower. And this is morning glory disc. Optic disc. It is an optic disc anomaly where the blood vessels are radiating away from the optic disc, just like the marigold. For your very interesting question, that's why I put it here. What is this chart? What is that chart? This chart very famous. Sierra chart. It is used for color vision. What is that chart? You see, the bold black letter is fading gradually. That means contrast of the letters are going down. When you see this type of image, this is called pelirruption. This is called pelirruption chart, and this is for contrast sensitivity. This is to check the contrast sensitivity. Understood? This is Sierra chart for color vision. That one is a pelirruption chart for the contrast sensitivity. For the color vision, we have different instrument also. This is one of that instrument. What is this called? This has been asked in the examination. This is called Farnsworth-Munsell 100U test. There is another one instrument like this only for testing the color vision is Farnsworth D15 test. So I will write here, this is for color vision. Now I will write other instrument is Farnsworth D15 test, और इशारा तो है ही, इशारा चार्ट also for color vision. This is very important.